Hello everyone, my name is Abdul Salam Alvi and I'm a graduate of Ziauddin Medical University. So recently I had the opportunity to complete a focus elective and today I'll be presenting the topic Pericardial Effusion Ultrasound. So the objectives of today's presentation include review of the existing literature, indications for the ultrasound protocol, and the pathology itself. So starting off with a literature review, echo remains gold standard to identify pericardial effusion. And echo demonstrates fluid collection in the pericardial space, and clearly you can visualize the features of tamponade on an echo easily. Moreover, the American Society of Echo clinical recommendations for cardiovascular imaging in patients with pericardial disease of 2013 suggests echo to be the initial procedure of choice for pericardial effusion because it's very easy to perform and it has about an accuracy of 100%. The 2015 European Society of Cardiology guidelines for pericardial disease suggest performing echo in all patients with suspected pericardial disease. So usually you should perform this in addition to performing physical examinations or chest x-rays, which are usually not as accurate. You should perform an echo for not just for pericardial effusion, but for all pericardial diseases. Moreover, interestingly, in 2021, a recent retrospective study focusing on point-of-care ultrasound for pericardial effusion found that it specifically expedites the time to diagnosis of pericardial effusion. So for the scanning protocol, you start by explaining the procedure to the patient, what they can expect from the examination, what the limitations of the examination may be. For adequate exposure, you must expose the patient from the anterior chest to the upper abdomen. You should ideally use a cardiac probe, but an abdominal probe may work as well. And you must make sure that you use sufficient gel to allow for enough contact between the probe and the skin directly. So the first view that we obtain is called a parasternal long axis view. For this view, you position the probe along the left sternal border, as shown in the video, between the third and fourth ribs. And you make sure that you aim the probe to the patient's right shoulder, as shown in the video. Ideally, the patient should be in a left lateral decubitus, but a supine position can work too. And you should be able to identify the following structures: the posterior side of the heart, the left atrium, the mitral valve, the left ventricle, aorta with the aortic valve, and the right ventricular outflow tract. If there is presence of pericardial effusion, it will appear in the image as an anechoic structure or a black colored structure, as shown in the image here. So there appears to be a fairly large amount of pericardial effusion present on the posterior side of the heart. Finally, a very important thing to note for includes the presence of a tamponade. You do this by observing the right ventricle, the filling of the left atrium, and the septal motion of the interventricular septum. For the short axis view, we rotate the transducer 90 degrees from the long axis, and now the transducer pointer should face towards the patient's left side. Here, we should be able to visualize the left ventricle, the papillary muscles, and the right ventricle. Similar to before, a pericardial effusion would appear as an anechoic fluid. For the four-chamber view, or the four-chamber subcostal view, we place the cardiac probe 3 to 4 centimeters below the xiphoid, and we place the probe marker facing the patient's left. You may have to require slight pressure into the abdomen, and as shown in the video, and you should also have an anterior angulation of the probe. So the four-chamber view or the four-chamber subcostal view is particularly sensitive to assess for pericardial effusion, and it's the view that is used in ultrasound-guided pericardiocentesis. Here we can see the right ventricle, the left ventricle, and the atria. This is a view showing effusions, again on either side, appearing as anechoic fluid collections. So generally we have 3 grades of effusion, and these are based on the measurement of the pericardial effusion depth using the ultrasound. We have small, which is less than 1 centimeter with only posterior effusion. We have moderate, which is 1 to 2 centimeters with circumferential effusion, and large, which are greater than 2 centimeters circumferential effusion. So the grading of effusions are particularly important because effusions which are significant require periodic reassessments for the potential development of tamponade, which could lead to rapidly decreasing preload and hypotension. So the causes of pericardial effusion are diverse, and they're classified as neoplastic, infectious, traumatic, cardiac, and others. For neoplastic, examples could include leukemia, lymphomas, or metastatic from lung, breast, or melanomas. For infectious causes, the most common causes include viral, but you could also have bacterial, mycobacterial, or parasitic causes. In traumatic, you could have something like trauma, iatrogenic causes, or aortic dissection. Cardiac causes include post-MI infarction and congestive heart failure. Finally, others includes radiation therapy, uremia, or idiopathic causes. So a quick note on tamponade. Tamponade is a life-threatening condition. In this condition, the pressures of the pericardial sac become equal to or greater than the right ventricle. This means that there is decreased preload, and decreased preload could, of course, lead to hypotension. So it's very important to rule out via ultrasound and or clinical finding. So what exactly are the ultrasound and clinical findings of tamponade? The clinical findings of tamponade include hypotension, tachycardia, and pulsus paradoxus. And the important ultrasound findings of tamponade include distended inferior vena cava, right ventricular collapse, and right atrium collapse. So if you have these findings of tamponade, emergent pericardiocentesis is warranted for these findings. A few important pearls and pitfalls to consider. It's very important to differentiate pericardial effusions from pleural effusions. So pericardial effusions stay anterior to the descending thoracic aorta, and pleural effusions are found more posteriorly. Sometimes it may be necessary to obtain multiple views to clarify and differentiate between pericardial and pleural effusions. If there are concerns of a tamponade, do not perform diuresis because tamponade is preload dependent. Look for other causes of symptoms as well. Even if you have pericardial effusion, it may not necessarily be the cause of the patient's symptoms. So it's necessary to look for other causes as well. Right-sided heart collapse does not occur with high right-sided pressures. So if there's cor pulmonale and there are very high right-sided pressures, and even if there is a true tamponade, there may not be collapse of the right-sided heart because of the high pressures. So these were the references that were used in the presentation, and that brings us to the end of our presentation. Thank you all for paying attention.